Let's start with a case. A 35-year-old man comes back from Cameroon after spending 6 months in the rainforest. He complains of itchy swelling on his arm that appears suddenly and disappears after a few days. One morning, while looking in the mirror, he notices something crawling across his eyes. On closer inspection, a thin white worm is seen moving under the conjunctiva. The classical presentation immediately points towards Loiasis, the African eye worm infection. Coming to the etiology and the transmission part, loiasis is caused by loa, a filarial nematode. It is transmitted through the bite of Chrysops flies, also called deer flies or mango flies. These flies thrive in the rainforest streams of West and Central Africa. During blood meal, a fly introduces the infective larva into the human skin. Here's the life cycle. The Chrysops fly bites and deposits L3 larva into the skin. The larvae migrate into subcutaneous tissue and mature into adult worms over several months. Adults can live for 10 to 15 years. The adults produce microfilariae which enter the bloodstream. Microfilariae shows diurnal periodicity peaking between 10 a.m. to 2 p.m. When another fly bites during the time, it ingests the microfilariae, which mature inside the fly into infective larvae, completing the life cycle. Clinical features. The manifestations depends on whether the patient is endemic, resident, or a visitor. In endemic population, loiasis is often asymptomatic. When symptoms appear, they include calabar swellings, transient localized angioedema. Migration of worm across the conjunctiva is a classical African eye worm manifestation, in which visitors or non-immunized individuals' allergic symptoms dominate, like frequent calabar swellings, itching, and urticaria, or marked eosinophilia and eye antifilarial antibodies. Rarely serious complications like nephropathy, encephalopathy, or cardiomyopathy can occur. Pathology. The pathology is largely due to hypersensitivity reactions to warm antigens. This explains why calabar swellings are transient and why non-immune individuals show more severe allergic symptoms. Diagnosis of loiasis can be made in several ways. Direct demonstration. Microfilariae in daytime, like peripheral blood smear or extraction of adult worm from the conjunctiva or subcutaneous tissue. The morphological features like length 250 to 300 microns, the nuclei extend all the way to the tip of the tail is a key feature. In adults, it's a long, slender worms found in subcutaneous tissue covered with cuticular bosses, a unique identifying feature of loa. Then other methods like PCR assays and serology are high sensitivity. In travelers, like diagnosis often supported with eosinophilia and antiviral antibodies. Treatment includes the drug of choice is diethylcarbamazine, dosage of 8 to 10 mg per kg per day orally for 21 days. It kills both adult worms and microfilariae. However, multiple courses are often required. Major concern is severe reactions in heavy microfilaria. Killing too many parasites at once can trigger intense inflammation, even coma or encephalitis. Alternative and contraindicated drugs like albendazole can reduce microfilarial load, but it is not curative. Ivermectin can also lower the microfilariae, but it is contraindicated when microfilarial density is very high. In such cases, ivermectin has been linked to severe encephalopathy and even death. Prevention strategies focus also on vector protection and chemoprophylaxis. Vector protection like wearing long clothes, using insect repellents, and avoiding swampy forest areas. Chemoprophylaxis weekly DEC 300 mg has been shown effective in high risk population. So personal protection, prophylaxis together help reduce transmission. So to summarize, loiasis is caused by loa transmitted by Chrysops flies. The hallmarks are calabar swellings and the African eye worm. Then microfilaria are sheathed and have nuclei extending to the tip of the tail. Adult worms show cuticular bursts. Treatment is DEC, but always with caution in heavy infection. Prevention relies on fly protection and DEC prophylaxis. That's all for the today's session. If you found this helpful, don't forget to like, share, and subscribe to more high yield medical topics.